Hi, everybody. My name is Liz Bayliss. I'm an family physician and investigator at the Kaiser Permanente, Colorado Institute for Health Research, and Lucy Savitz, who is the vice president for health research at Kaiser Permanente Northwest Center for Health Research, and I have been working on a paper called Models of Care of High Value Care for Persons with Multiple Chronic Conditions. And we're going to summarize a little bit of what we've been working on for you. And the way we're going to do this is to tag team our presentation a little bit back and forth. So I'll start out, and then Lucy will get on and talk for a couple of slides, and then I'll wrap up. So as you can see, this is the topic of the paper we've been working on. And the rationale, as many of you are probably familiar with, is that 1 in 4 Americans and quite a few people over the age of 65 have multiple chronic conditions, which we define for the purpose of this paper as 2 or more chronic medical or behavioral health conditions experienced by the same individual. Our healthcare system, which was designed for single diseases, doesn't work so well for people with multiple chronic conditions. There is poor communication between providers and between providers and patients. Care coordination is tricky. Decision-making gets confusing for patients and their families. And really the upshot of the whole thing is there's really not enough attention to patient needs and goals, and there's room for improvement. However, to guide that improvement, there really isn't enough evidence that's been generated for care for this population to really guide systems and delivery systems that are working on improving multiple chronic conditions care. So the objective of our work was to take a step in that direction and characterize some successful models of high value care for people with multiple chronic conditions. And then later on at the end of our work, sort of toss out a few ideas for a research agenda. Our
Great.
approach, Lucy, is this for you to start in? Yes. Go ahead.
That's okay. Thanks, Liz. And it's a pleasure to be with you today and highlight this important work. Our approach was really to begin with the literature. So we did a rapid literature scoping over the last 5 years, looking for evidence-based models of high value care. In addition, we wanted to do a reach out to clinical experts in the field who were treating this patient population. So we identified a proposal sample of these experts, and we were looking really in these interviews for timely strategies of care for individuals with multiple chronic conditions, trends that hadn't been previously reported in the literature, and to understand a little bit about the impact of COVID on care. These results were triangulated to produce the findings that we're going to highlight for you. Next slide, please. So, the findings from the rapid literature scoping, we identified 14 studies, 7 were prospective, and you can see the designs listed here, and 7 were retrospective. And there weren't a whole lot of surprises. The main surprise was, I would say, we didn't identify one or even a handful of leading models of care. And when you think about a model of care, it tends to be a complex intervention with multiple components. What we did see is the frequency of a number of components identified across these studies. So we're starting to see components of studies that are going to be no surprise to anybody here. You'll see coordination, communication, social support issues, transition management, team-based approaches. And then there was a focus on evaluation of outcomes, specifically focused on utilization and cost. In particular, 4 of the studies looked at quality of life, function, clinical outcomes, and patient experience. Next slide, please. And what we're trying to do here in this slide is to really summarize some of the qualitative findings from the study and the 9 systems that participated. I will say that those systems were geographically varied. They had different payment models. They had either more strong or less strong infrastructures that integrated the care delivery process. But in this agreement chart, you can see the kinds of themes that identified as we did our synthesis of the data that we looked at. And again, you know, you're seeing a lot of repetition across the things that we reported. But in the next slide, when I highlight the findings for you, it's a couple things I want to be sure to point out. And Liz and I spent a lot of time talking about these. One key informant really characterized care for these individuals as really a wicked problem. It's multidimensional. It requires a patient-centered approach from a multidisciplinary team. But almost to a T, everybody talked about the fact that in identifying and addressing multiple chronic condition care, it means you must address social complexity. And the role of the community and how the community is engaged in that process really emerged as an important aspect of the care delivery. So it's not just care. And this next bullet really characterizes that. So what we're starting to see delivery systems doing is not just focusing on the care when somebody's within the walls and doors of their clinics and their hospitals, but looking at what was characterized as between care time, so moving upstream. The other sort of challenge that was identified by a number of our key informants was the need to align financial incentives. So outside of, you know, a risk-based environment, there are really sort of problems and challenges to aligning the financial incentives between the delivery system, the payer, and then the benefits to the actual individuals who are being treated. There's a lot of heterogeneity in the population, and so from a population management approach, it's really difficult to characterize patients into bundles just based on the number of chronic conditions that are counted. And then in COVID, and I think this has in large part due to necessity, but it also has to do with regulatory relief. We're seeing expanded use of home-based care. But one of our key informants really talked about it as the care that is most convenient. It's easiest for the patients to receive care in their own home, and the increased use of remote devices and remote access to that care. Next slide, please. So
based on the work that Lucy just described and the interviews and our synthesis of the findings of talking to people, plus that literature review, we've sort of started to assemble a possible research agenda that we think would better inform really holistic care for people with multiple chronic conditions. And the first area is one that's already in progress, but that we feel that there's still plenty of work to be done, which is really understanding the heterogeneity of the MCC complex patient population. What we've learned is that we all know that there are multiple actionable subgroups within the very heterogeneous population, but there are quite a few that are rather less recognized. For example, we may be familiar with the end-of-life population or frail elders, but there are plenty of people with multiple chronic conditions who are working adults who may face different challenges that really we in the delivery system do not understand well enough yet. Another finding that's emerged is that rising risk populations of groups of people who are developing more chronic conditions or who are adding complex needs to their care regimen, it's a dynamic population. This shifts over time. And so it's really not a linear progression, and there's room to explore how that's evolving. There's a real need to develop patient-centered outcomes for evaluating interventions and programs of care delivery for people with multiple chronic conditions. For obvious reasons, there's been a huge emphasis on utilization and cost of care as primary outcomes for evaluation. As Lucy mentioned earlier, there was a minority of studies that used quality of life and other patient-centered outcomes. And part of that, I think, is because they're difficult to use at scale, and there's room for developing really novel outcomes as well. All of the participants that we spoke with talked about the importance of addressing social needs, and there's work to be done to not only identify what social needs people have, but to efficiently work with community partners, including potentially exchanging data to make those collaborations really efficient and effective for patients. Implementation science has not yet been applied a great deal to the care of patients with multiple chronic conditions, but there's the potential to really learn from studying the implementation of programs in one setting and applying those in another. And so hopefully implementation science can add to that body of evidence. Certainly getting a better handle on misaligned financial incentives and using an economic analysis of long-term, not just short-term costs as part of understanding the need for better alignment, as well as using studying the effects of different reimbursement models would go a long ways towards helping systems implement models of care that are both effective and efficient for systems. There's certainly plenty more to a research agenda, but these are some high points that we think could and should be addressed sooner rather than later. And that is all that we have for this summary. We would certainly welcome any questions through these meetings or directly to us, and you can see our email addresses there.